And then you have to explain why and what the goals are with the padding and why we're going to try and reconstruct this limb. So we design all these kind of crazy incisions, and there's many different ones that have been designed. Long posterior flaps, sagittal flaps, skew flaps. They have different names and different designs. We try to avoid thin skin. The anterior skin is very thin, and we try to avoid using that. And sometimes then we'll even do these kind of drawings, and we will be highlighting where does the skin actually fold from. You have to know where it folds from to know how long to make it and how long to design it. And so we often have these discussions in the operating room that the skin really folds from the back and wraps around. And you need much more skin. It's interesting. It took me a while, and I think it was, again, another nurse that pointed out to me, the patients really don't understand. There's somehow this view that everything's just kind of cut off at one level, like might happen in an old French guillotine. And then how does it magically get covered and closed? And actually doing little drawings about we're going to move this to here to provide the padding helps the patients understand and get it. And those kind of discussions get people involved and, one, make it a little more real, but also make it a little less scary. So I do a lot of drawings with the patients, and we write on their leg. I actually take a pen out and mark pictures about where we might do things. And that really helps, I think, people understand. The nerves. There's 5 nerves in our calf. Those nerves are like hot wires that have a lot of signals going downstream and upstream. And we need to think about those to make sure we know where they're at and try and manage all the nerves and shorten them so they're not going to be trapped in areas of scar and pressure and blood vessels. And it's interesting, many people unfortunately have had surgery that's probably not done with the best of techniques. And I look at their operative note or talk to a surgeon, he said, yeah, and I found the nerve. Like, the nerve? Yeah, that tibial nerve. I found that tibial nerve, and we took care of it. And I said, well, what about the other 4? And it's like, oh. Unfortunately, that happens sometimes. Amputation's not looked at as the most positive of surgery. But there's 5 nerves that ought to be addressed and really managed. And here's just a little schematic. You know, the saphenous kind of running down the medial of your calf with a big vein. And our perineal has a superficial and a deep portion. And the tibial nerve is the big nerve that's in the back of our calf that gives the feeling to the bottom of the foot. And a small nerve called the sural nerve is very small, but often creates a very tender spot at the end of the amputation if you don't think about that nerve and really stretch that nerve down so that it retracts. And the end of the nerve is not in the area where it's going to be a problem. When the nerves are cut, they try to regrow, and they form a little mushroom of nerve tissue and scar tissue that can be really sensitive. So if you leave that in the scar, it will get entrapped and create a painful neuroma. Or if you tie it right near a blood vessel, it can sense the cadence of the vessel, and people might feel a throbbing inside the leg. Blood vessel groups. There's 3 major ones in our calf, and we really need to address them to make sure, one, bleeding is bad. So you really need to securely ligate the vessels so you don't have any bleeding afterwards. And we try very hard to avoid getting the nerves and the vessels close together, because we don't want the vessels sensing the cadence of we don't want the nerves sensing the cadence of the vessels, causing a throbbing feeling. We think about muscles in 4 compartments. And interestingly, 3 of them, we really shorten the muscle near where the bone is. But the major one, the back, the calf muscle, the gastrocnemius and the soleus, are brought up with their muscular investing fascia. The old technique was to cut through the muscles and leave them beveled, and now we leave them thicker and better covered to be better padding. And here's the bones, some example of the kind of saws that we use in the operating room. It's a saw that vibrates, and it cuts through bone, and we're cutting a tibia right in here, and here's where we're dividing a tibia. And we put a bevel. The tibia is like a triangle, and if you leave the point, it's going to hurt people. It's going to be hard to wear the prosthesis, so you have to shape the bone. And in the bottom, when we're shaping the smaller of the 2 bones, the fibula, and you need to cut the one a little shorter than the other. There's an interesting kind of concept that's come and gone since World War II called bone bridging. There's a physician named Ertl in Hungary who decided these 2 bones are kind of joined near your knee, and they're usually joined near your ankle. And in an amputation, they're no longer joined. And there's big debates on whether rebuilding a connection to those bones can really help or not. And there's a lot of theory. I get patients that come in a lot with internet articles saying, I need this. You need to do this bone bridging thing. And sometimes they're right. It would help. And sometimes there's downside to everything. Maybe it won't heal. Maybe it will get infected. Sometimes if you try to do too much, you can end up worse off. So we counsel people on what the theory is, and this is a great example, and what the reality is. And I usually tell them I'm very supportive of these reconstructive concepts. I think of this as a reconstructive operation. But the reality of some of these things doesn't always equal the internet hype. And I found our medical practices these days, we're often discussing what's on the internet. Because the patients bring you, they will bring you as medical students, they will bring you these articles and say, what about this? I need this. And so you have to understand what's out there and what the patients are coming forward. Here's a case where it was very appropriate, very severe trauma, and the two bones were splayed apart. And if we had left them like this, it would have been very difficult in the prosthesis. So we actually did build a connection between the two bones with a block of bone and a screw to reset them more anatomically. And so sometimes this really does make sense. And there's other times where if someone has an infection, you really worry that this will just cause more infection. So we have to have those kind of conversations. And then we close things up. You know, a myodesis, sewing muscle to bone is what myodesis is. And you can do it in a couple ways. You can sew it to the periosteum or the covering of the bone to get a secure fixation, or you can actually drill holes in the bone and place suture through the bone and sew the muscle right to bone. And then the fascia, the envelopes that cover our muscle, we need to close that to keep the muscle contained and help it to heal. And then we have to think about the skin. Many of our patients heal very slowly. Folks with diabetes or vascular disease often don't heal as fast as when they were 17 years old. So often we have to consider that these stitches might be in 3 weeks, 4 weeks, 5 weeks, 6 weeks. How are we going to maintain a situation that's okay through a longer healing time? Why is padding so important? Well, Dr. Burgess, who is an orthopedic surgeon from Seattle, he passed away a few years ago from a stroke, but he invented the Seattle foot. He taught reconstructive amputation surgery for years. I came out here, he was one of the 2 people I really wanted to work with when I came out here, and I was privileged to work with him. And he popularized a Burgess-style amputation that we use a lot. But sometimes the padding can fade. And here's an example where the padding used to actually be up over the bone, and over time it's stretched out. Unfortunately, the human body sometimes stretches and sags. And I'm 48 years old and starting to stretch and sag. And it happens even more sometimes as we get into our 60s. So if the padding shifts, you know, even though we positioned it, this can be a problem because it's a pressure point in the prosthesis. There's some solutions the prosthetist will talk about to make it better, but surgery can sometimes help. And we've tried to do things, especially for our younger patients, for extended padding. And it looks really bulbous and puffy because your muscles are actually big, but over time they thin down. And a situation like this ends up here where someone actually has more padding up and over the bone. And so see, these are some of the positive things we've been looking at with surgery to help people, not just with their healing, but also with their rehabilitation and with their interface with their prosthesis, their artificial leg. Here's another gentleman. He was 70, horrible osteomyelitis for years, flare-ups and flare-ups and flare-ups. And the interesting thing is this was very severe infection and worries of turning into squamous cell cancer, which wounds that are 8, 10, 15 years old can do. This part was all skin graft, just stuck to his leg, would not have held up to the forces of an artificial limb in walking. He had good circulation. Fortunately, he was 70 and had never smoked his whole life, and he was very healthy. And we actually used a huge flap, as you can see here, and really inset this to make a padded situation. And he healed and got back onto life. And actually, once his infection was gone, he said, it was like getting rid of the flu. I'd felt like I had the flu for 20 years. Everything was always achy, and I'd respite these fevers. And he said, now that this bone infection is gone, I no longer feel like I have the flu. He also said food tastes better. We had to caution him, because food tastes better, you often gain weight. And he said, you got to be careful. Now that food tastes better, you got to really watch out. The last thing I want to talk about the surgeon's role is attitude. And I believe that positive attitude is absolutely the most important of the 3. Often it is the hardest, especially if you're facing something like an amputation surgery or a discussion. The execution of the surgery, excellent technique should be expected. But by attitude, I mean the coaching and positive motivation. And I think Dr. Chernicki will be coming up in the rehabilitation side of things, amplifies that we really, as physicians, we need to coach our patients to positive outcomes. Our job doesn't end when we put the last stitch in. It's our job, like the coach of a team, to get the players to perform a little better. And if someone is really faltering in their postoperative healing, I've seen surgeons blame the patient for that. And I sometimes step back and say, well, is it the patient's fault or is it the coach's fault? Because as surgeons, we need to be coaches. And I think this is a bigger part of the job than I was ever taught. And then the more I'm in this field, the more I realize that a big part of a surgeon's job is this coaching and positive motivation. I would like to, as in many medical student talks, give you a couple of resources. There's a couple of great websites that have a lot more, both the first one on surgical technique. It's one that I'm actually proud of because we're trying to teach more people the positive aspects of surgery through a website. And if you are not afraid of the gory details, which you're all here, so you're not, you can actually watch amputation surgeries on that website. The second one, In Motion Magazine, is the official magazine of the Amputee Coalition of America, and there's a lot of articles directed to people facing limb loss who have had limb loss that gives tips and tricks and what it's like to live without a leg. And you'll get some of that tonight, but you can get a lot more at the website. So I'd like to thank you for my part on listening to my part on surgery.
So that said, I would like to have our panel come up of amazing people, and you can ask them a few questions about what it's like to live with a prosthesis. So could we now have our panel members please come up?
To start off with, I think it would be great to have each of you introduce yourselves to the audience and just sort of let them know a little bit about yourselves, just in general terms, and then we'll kind of move forward from there. Laura, do you want to go ahead and start?
Good evening, my name's Laura Willingham. I'm 30 years old. I'm an above knee or transfemoral amputee. I was in an auto accident when I was 21 years old, and my right leg was severed. And I've chosen to work in the field of limb loss and limb difference through the ACA, and I've had the honor and privilege of working for Prosthetics Research Study under Dr. Smith. And now I serve as the regional representative for the Amputee Coalition of America, working to link other amputees to one another in the Pacific Northwest.
Thank you.
And Jim McDuff, as Danny once said, when I help him during the summertime with his patients, or with his kids down there, and Mac's an ideal patient. He has everything wrong with him. But anyway, 4 years ago, diabetes. I got a bad ulcer on the left foot. When I checked into emergency, I had about 36 hours left. I waited too long. Male pride got in the way. Also suffering from neuropathy on the right leg. And to summarize that, no feeling here, no feeling here. It makes walking a real sport. But I try not to let it get me down too much. I carry a 15 golf handicap still and enjoy life just as much as I can.
Thank you. Dee?
My name is Dee Malco. I'm a retired nurse from Harborview. I was in a boating accident when I was 19 years old, which was about 43 years ago, so I won't tell you how old I am. When I worked at Harborview, I was a part of an effort to set up a special program to smooth out the impact of amputations. And the support group is still going there, and the program is very viable. So it was a privilege to do that. I'm married and have 2 grown children. I have 6 grandchildren. And I'm now focused on working with amputees in West Africa.
Thanks, Dee.